Hello everyone, this is Renee Clark. Today we're going to be learning about gentle midwifery care, intimate partner violence, also known as domestic violence, and woman-centered care, especially following sexual assault. Intimate partner violence is a sobering topic. It's very common, and as nurse midwives, you will come across clients who report domestic violence to you. It's important that we know exactly how to screen all women in our practice, both during annuals, first problem visits, and in prenatal appointments. Most important is to understand exactly how to screen, intervene, and then follow up. We'll talk about this later in the presentation as well, but it is always up to the woman whether or not she reports and whether or not she chooses to leave a partner. As healthcare providers, our goal is to support women and to be a sounding board in terms of information as they make up their own minds in their autonomous relationships. As a rule, I don't generally read slides in PowerPoint presentations, but I do believe that the ACNM position statement regarding domestic violence is really important for all of us to hear. This is our professional organization, so I will read this, especially if you have an earbud in as you do the many things you have to do to keep your day going. Violence against women is an enormous public health problem which adversely affects the physical, emotional, and mental health of millions of women and their children. It affects all racial and ethnic groups, all religions, all economic and educational levels, and in heterosexual and same-sex couple relationships. Abuse may be verbal, physical, emotional, sexual, and/or economic. ACNM supports a policy of zero tolerance for violence against women. In recognition that many women disclose violence in their lives to their healthcare providers, it is essential that there be the development of healthcare policies that promote universal screening for the possibility of past or current violence. Most women who report intimate partner violence do so to a healthcare provider, which is why it's essential that we understand how to move forward with screening all of our clients, educating once we have a positive screen and/or somebody reporting intimate partner violence, an interdisciplinary approach to referral, so counselors, and then providing medical treatment, whether it be STI treatment or injuries sustained during domestic violence dispute, and then ensuring really close follow-up care. I think the follow-up for midwives is something that sets us apart and is unique in terms of that holistic full circle care so that our clients aren't lost to that follow-up. We will do so in a safe place, so psychologically, in that we are empathetic and we go slow, both in our physical exams and also in history taking. Make sure during both you're in a private setting for clients. And in that follow-up, most women will come back to you if they feel that safeness. We'll talk a little bit more about mandatory reporting, which I believe is a huge topic that falls under safety. I'll save that for later, but keep in mind that mandatory reporting is something that we'll talk about and is really important for you to understand as a healthcare provider. I wanted to include some important U.S. statistics regarding IPV and sexual assault. Between 2.7 and 13.9% of women experience IPV every year. The chasm in those numbers is in reporting. Lifetime prevalence of IPV is actually highest in bisexual women at 61% compared to heterosexuals at 35% and lesbian women at 43%. It's important to understand this if a woman reports being bisexual, understanding that her risk of IPV is higher. Women who've experienced intimate partner violence are also at a higher risk of contracting STIs, which includes HIV. Subsequent to IPV, women will have higher rates of depression, anxiety, PTSD, alcohol and substance abuse. Women suffering from these should be asked about sexual assault history. Of note, the National Domestic Violence Hotlines receive an average of 20,000 calls each day. That's how prevalent this is. 1,200 IPV-related homicides against women occur every year. It's most common in women between the ages of 18 and 24. And for sexual assault, 1 in 5 women in the United States is raped in her lifetime. These are very sobering statistics and so important for us to understand as nurse midwives, as we are often the first line that women come to for reporting and for help. If a woman comes to us and we don't know where to send them, that is such a disservice to the women that we seek to serve. So this PowerPoint is by no means comprehensive, but I am hoping to show you tips for screening, making sure that your clinic is doing screening for all women, and then follow up locally for resources, which we'll talk about later. There are also links here for each state in terms of mandatory reporting and what we see for IPV resources. So make sure to follow that later. And if you're listening, take a second to open this PowerPoint slide when you have a chance and click on some of those links that are coming. IPV, domestic violence, is a multifaceted problem. The economic effects for women are also staggering. It is reported that 21 to 60% of IPV victims lose their job stemming from circumstances related to their abuse, and often this is fear of coming to work with bruises or injuries. So a woman who's suffering from this is also isolated economically. And the U.S. economy spends between 5.8 and 12.6 billion every year on IPV-related expenditures. So this is something that the United States is paying more attention to, and I think it's very important to understand that in these last years, 2017 and beyond, in the Me Too movement, which I appreciate, has brought it to the forefront and the stage here in the U.S. But understanding as healthcare providers what to do with these reports is the most important. So understanding that they occur is vital as a first step, and now understanding where to go from here is one of the most important things we can do for the women that we serve as nurse midwives. Screening for intimate partner violence should be a standard protocol within every setting, whether it's a standalone clinic, birth center, within a hospital. Screening should be done at every visit, including annuals and problem visits. It should be written in an intake form, but then also reviewed face-to-face with your client verbally. Oftentimes a woman is not apt to write down or confirming violence, but she will verbally report to you, so both are important. And anytime you suspect intimate partner violence, it's important to do that, whether it's prenatal or postpartum, etc. Make sure you're always in a private setting with the door closed. Confidentiality must be discussed. In the next couple of slides, we'll talk about mandatory reporting, and I know I keep bringing this up, but it's such an important topic when we think about confidentiality and whether or not our clients will divulge or report intimate partner violence to you. There is poor evidence based on a WHO research study about routine screening if it's done without provider knowledge and referrals in place. So for all settings, considering an in-clinic advocate that addresses intimate partner violence and then provides in-service trainings for midwives, nurses, anyone that comes across clients or asks these questions is really important. So the screening and the immediate follow-up during that same visit face-to-face. So advocates, examples, they can take the lead in developing policies and procedures around screening. They can provide that in-service training, especially regarding referrals and local resources, which are likely to change throughout the year. And then developing patient education resources, and those are generally placed in bathrooms with hotlines, so clients can call if they don't feel comfortable verbally reporting to their midwife. And then also those advocates can lead continuous QI, quality improvement projects, to ensure that your clinic is doing a robust job at screening and then the important follow-up. I've talked a lot about screening tools, but here's what you'll actually use. So there are 6 listed on this slide. Recommended by the United States Preventative Services Task Force is the first, HITS, H-I-T-S, which stands for hurt, insult, threaten, and scream. It is the most common and recommended for the primary care setting. It is available in Spanish, which is excellent, and it's a quick 4-question tool. I have an image of it on the next slide. The following 5 are also used. It doesn't matter in your clinic which you'd like to use. There should just be, again, a standard protocol that all of your providers or nurses are offering to clients so that nothing is missed. Continuity is always most helpful when you're thinking about screening tools, especially for intimate partner violence. So take a quick peek at the next slide. We're going to touch on HITS and see exactly how women might answer that. So this is the HITS screening tool. You'll notice the 4 questions along the side: the hurt, insult, threaten, or scream. As a healthcare provider, you'll then score it. The lowest score possible is a 4, highest possible is a 20, and anything at 10 or above would essentially put you at risk for domestic violence. So this can be done, administered by anyone in your office: MAs, nurses, physicians, midwives. But as with any screening tool, if it's not administered by you, if it's administered by a nurse or an MA, you should be reviewing it prior to the client leaving the clinic. And that's true with any screening tool, but especially with IPV. This is a list of examples, clinical conditions associated with IPV, and this comes straight from the World Health Organization article that is listed in the reference section of this PowerPoint if you wanted to take a closer look. Essentially, screening obviously should be done for all women, and at this point you're also catching women who are presenting without signs and symptoms of IPV. Regardless of what the screening tool shows, you should be aware of the clinical conditions that victims might come to your clinic with, which would then prompt you to specifically ask about IPV. So some of those listed here we've already spoken about: depression, anxiety, PTSD, also sleep disorders, any self-harm, pelvic pain, and sexual dysfunction are important ones and common. Commonly you'll see frequent terminations and unplanned pregnancies, unintended, and generally this is due to, when it's related to IPV, it's due to forced intercourse. Genitourinary symptoms also because of violent intercourse, so frequent UTIs or kidney infections, STIs including HIV that we talked about, traumatic injuries that are vague, and you'll find this throughout the body, but also pelvic related during annual exams. Headaches, cognitive problems, hearing loss, and a lot of these are also reported, subsequent to stress and anxiety in a woman who has violence in her daily life. And then an intrusive partner or husband in consultations. This is an important one I wanted to touch on briefly. And again, we have to be really careful about how we view relationships and approach them in a non-judgmental way. However, when you are in a clinic setting with a partner who comes along for all visits and you find that they are reluctant to leave the woman during an exam or during history taking, sometimes that will happen with an abusive partner. So this is why we often post information and hotlines about IPV in restrooms where partners are less apt to follow their partner into the bathroom, although sometimes that still occurs. This is why it's important to post that literature and helpline numbers. So take a quick peek at this box, and again, there's more detail in the WHO article placed in the references at the end of this presentation if you're interested. As nurse midwives and healthcare providers, we are first-line support. Women who have divulged or reported IPV to you will then experience either a non-judgmental, empathetic, supportive interaction or a judgmental, questioning demeanor. And it's one of the reasons as nurse midwives that we are in that unique position, frequently because we have longer appointment times, not always, but frequently we do. We also have more availability for continuity, and a woman with a history of IPV will often seek that continuity, especially after reporting. It's hard to divulge that information, and emotionally for her, finding one provider who she feels safe with and continues to trust will be instrumental in the next step she chooses to take in either reporting or leaving a violent situation. And again, as healthcare providers, we are simply there to ensure privacy, confidentiality, to be non-judgmental, and to validate all of her concerns and anything that's occurring in her life subsequent to that abuse. So we are literally, again, that sounding board to her. Respond to her concerns and then let her be the one to take action, but she will then have the option to take action based on what we provide her for local and national resources. Oftentimes, women will initially report domestic violence but not want to tell the details. We should never pressure her to disclose those details. That's less important in the moment. What's more important is that we offer referrals and support in terms of counselors, so interdisciplinary care, knowing your local resources in terms of legal representation. It's really common for abusers to segregate the women away from other friends, family, and often removing financial resources so that she can't leave or to deter her from leaving. So legal representation is important as well as financial assistance. There are always local safe houses and providing websites or literature that she can view in clinic, but always reminding her that it might be safer not to take those with her unless she has a safe private place to keep those confidential away from her partner. Follow-up appointments, of course, are really important. I always try to ensure that a woman has that follow-up appointment before even leaving the clinic if possible and if amenable. And then always helping her establish a safety plan, and this could mean many things. So included in the list above, adding details. So if she's thinking of leaving her abuser, simple things. Where are you headed? So knowing either a safe house or a friend or relative where her partner might not know how to get to. Another is to keep person keys in a specific place so that if she had to leave rapidly, she would always know where to grab those. Most important as well is keeping weapons locked away. There's a statistic that a partner with a weapon puts a woman at risk of domestic violence and death increased by 400% if there's a weapon in the house. So trying to lock those away when possible. And then keeping those hotline numbers if she does decide to take those home, again, keeping those in a safe place. But again, anything that she does or doesn't do is up to her. As a healthcare provider, it can often be frustrating or concerning when a client who divulges IPV then remains in her situation for weeks, months, and years. And again, that is always up to her. We should just always be willing to be present with her anytime she needs us, regardless of any action or inaction that she takes. We have circled back around to mandatory reporting. I have mentioned it several times, and I hope what I've done is piqued your interest in doing further research regarding why there is controversy. Many national organizations, including the World Health Organization, states the need to amend current mandatory reporting laws. And this is specifically to protect the victim. As you can imagine, if a woman comes to you, reports abuse, and you then report to the state, you're putting her at risk from her abuser if she's remaining in the situation. As a healthcare provider, it is still very important to understand the laws in your area. So I have included the link at the bottom of this slide here. The article is written and supported by the National Health Organization, the DHHS, and it's entitled The Compendium of State Statutes and Policies on Domestic Violence in Healthcare. So if you start on page 2 under Implications for Victims of DV, this immediately talks about the controversy, which is helpful, and then following subsequently are a list of the 50 states, so you can understand what your current state or any state you hope to practice in, what their laws are. So take a quick minute to understand the debate and consider what mandatory reporting does for the women under your care. Women-centered care. This is something that midwives provide for all women and is also very important to ensure that we're doing for any woman who's experienced intimate partner violence and or sexual assault. The idea is that in the healthcare setting, especially in our current Western civilization, we know that we have time constraints in clinic visits. We have things that we must obtain quickly, whether it be blood samples, pap smears, pelvic exams, etc. And yet, anytime we come upon a woman under our care and we approach the room, we should remember that her needs and desires, both physically and emotionally, are more important than my needs and to-do lists during that clinic day. When walking in the room, make sure that you do a thorough intake form review. Ensure that she's answered the questions about IPV and sexual assault, and regardless, make sure that you're then verbally asking and offering the opportunity for her to talk with you more about that. If at all possible, and in my opinion, 100% of the time, I think that we can offer that history and first face-to-face while that client's dressed. Whether or not an MA, a nurse, LPN enters the room and takes blood pressure, they can do that with their clothes on. You come right behind them, do the full history, step away, let her quickly undress and get into a gown while you get your things organized, and then knock on the door and come back in. That is something that I've heard when offering this within a birth center setting, So many women have noted that to me in an annual exam, that's something that's so important and immediately sets that woman in a equal setting, as opposed to being cold and in a gown and trying to answer these questions. Offering longer appointment times is something that we can do in women-centered care, and again, that's not always possible, but if possible, we should offer those. Anytime a woman has a history of IPV or without, they should be offered a chaperone, whether that be a friend, a relative, and becoming more popular here in Boulder, Colorado, are doula chaperones, and that's somebody who is trained as a birth or labor or postpartum doula. But anyone with a history, because of that continuity, that doula can also then enter the room with the midwife and be present during this exam for the client if desired. Self-insertion of the speculum is something that Katrina has actually brought up to me, and I think it's fantastic. I have seen this several times, but it's definitely not a common practice, I would say. Anyone with a history, of sexual assault, anytime you're approaching a woman with an external object that is then going to be placed within the vagina, they should definitely be offered a self-insertion. That woman knows exactly how that feels, whether or not it's uncomfortable. She's able to go at her own pace and slow or stop if needed. This is not something that takes a lot of extra time. So it's something that as a student, I think it's valuable for you to attempt a self-insertion of the speculum and see if maybe some of the midwives that you're working with are also doing this. Respectful draping during the physical exam is also an example of women-centered care, ensuring that when a woman is in a butterfly position during a pelvic exam, the drapes are covering her body completely, and you're just removing the area that you need to remove in order to actually see the pelvic area for a full exam, speculum, pap smear, etc. The butterfly is something that I believe, especially in a birth center, we don't have stirrups. So it's something, stirrups in the hospital I was very comfortable with. It was something I didn't even question. And then now working in a birth center setting, having a woman, we use massage tables as opposed to general GYN exam tables. And because we don't have stirrups, all women are in a butterfly position. And this is This includes IUD insertions, pelvic exams, pap smears, etc. Look online if you're confused about exactly how this would work. There are some examples which I think are very helpful because change is hard, and some of the midwives that we work with will be opposed to this. And yet, as a woman, I think being in that situation, especially with a history of IPV or sexual assault, stirrups are cold. They place the pelvis in an often uncomfortable position, but also their legs are spread further apart, so it's a little bit more vulnerable. Everything can be done in that butterfly position, but you do have to be aware of how to use the speculum and other accommodations on the tables, including pillows. So take a second to look into that if you've never seen it. Anytime you touch a woman or you're about to touch a woman, you should ask permission to do so. And anytime a woman has a history of IPV, especially when you've discussed that in an annual setting, a simple, straightforward, respectful question is to ask whether or not she has any trigger words. Oftentimes, women will be able to say, yes, these words are hard for me to hear, especially in a vulnerable exam, and then you make sure you don't use those words as a midwife. It's a very simple thing, and I think sometimes we're afraid to talk about this. We're afraid to talk about sexual assault, especially with a woman who's experienced it, if we never have. But if she divulges it to you, you then talk about it in a respectful manner, but in a very straightforward way. This shows respect and also ensures that the woman understands that even if you don't do everything perfectly, you are trying. So simply stating that, let me know how I can care for you in the most gentle way possible is the best way to move forward in any physical exam, and honors the woman and her past experiences. I've included an example of a list of national hotlines that can be posted in the clinic setting or in the restrooms. Taking a quick peek at some websites that maybe you've never heard of, loveisrespect.org is a favorite. And you can also text them as well, which I think is excellent. Take a peek at these and just understand some of your national resources. And then when you're in the clinic setting with the midwives that you're working with, ask about local resources and whether or not they have a list that you can take a look at. Thanks for sticking with me on this. The next 2 slides are references. Everything pulled from this PowerPoint is in detail in the following 2, and there's some excellent articles there for nurse practitioners who are screening for intimate partner violence in the primary care setting. Any additional questions, let us know in the general forum.